thank you.
At home, I was like, wait, why is it not?
Okay.
Sorry.
That's okay, thank you.
No worries. So, just to back up terminology-wise, palliative care is an extra support that can happen at any stage of a progressive illness or any stage of any illness. It is for symptom management, goals of care conversations, patient and family support, and walking with people so they can understand what's happening to them medically. And we try to communicate between and among everybody who's helping to care for them, and then communicate that with the patient and their family in language that they can understand, so they can ask questions. Because so often, we tell them you have whatever, and they nod, and you think that they're getting it, and then you walk back in and they're like, oh, I have brain cancer. No, you actually don't. You have lung cancer that spread to the brain.
Mm-hmm.
All of those nuances, just to make sure we're communicating with folks. So when they have a power of attorney on file, that is not necessarily anything having to do with healthcare at all. It is not the same thing as a healthcare proxy decision maker. Power of attorney is usually a financial person who can go to the bank for the person and cash a check, who can pay their bills, who can do whatever. If they had a power of attorney form completed prior to 2007, that may include healthcare decisions. But anything from 2007 on, it usually has to be a separate paperwork completely. So what we can do in the hospital is we can help people fill out advanced directives, which includes they call it a State of Connecticut combined form, which the first part of it is a healthcare proxy decision maker form. In the event that you can't make your own decisions, who would that be? When we help the person fill that out, we always like to put the phone number of the person and put an alternate with their phone number, and then have it scanned into the system, and hopefully that will live here in perpetuity.
So where do you find that? And whose responsibility, or who's expected to kind of check that box?
So for you, you certainly can do it, the bedside nurse can do it, I can do it, anybody can do it. It doesn't need to be notarized. And you can find it literally if you Google combined form State of Connecticut, and it pops right up. And you can print it, and the care managers usually also have a copy of it that they can just hand to you if for some reason you don't see that on file. So, and I can send you the link if that helps. That's a bit easier.
And then if they already have one of those completed, where does that live in Epic or their chart?
Perfect, and that's exactly what I was going to say next, is that so you would think that it would be in the same spot, in the same way each and every time. But when you go into Epic, go under the demographic tab.
Okay.
And it's usually right there in the information on one of those tabs. It will say demographics, advanced care planning, documents, whatever. The other way you can find it sometimes is in the advanced care planning module, which is not what most people are using quite yet, but that's what we're hoping to kind of streamline. I'm going to show you that later. But for the most part, it's in demographics.
Okay.
So if they have one on file, that's beautiful. We talk to them about, is this, in 2018, you named your niece. Is that still who you want us to speak with? In the event that you couldn't, if that changes, we can just draft a new one. And then the new one, whatever one is dated the most recent, is the one that we have to go by, and the rest of them get null and void.
This is my way to deal with that stuff.
Okay.
I don't know what it.
That's
Sorry,
okay. No worries.
yeah.
Yep, no worries at all.
Will you forward that to me, please?
So then, once we've determined who the person would want to speak with us, do they have a living will, which is the second portion of that combined document. And the language of that is so not helpful much of the time, because it says, in the event of you're in the terminal stage of a terminal illness, how would you want us to care for you if that's where you are? So would you want us to provide cardiopulmonary resuscitation, intubation and mechanical ventilation, and or artificial nutrition and hydration? Yes, no, withhold, not, whatever. And then it's signed and dated and within the form. Where it's important for you all too is that is different from code status. What is reflected in there does not necessarily mean that when they're going to the operating room for appendicitis and it's going to be a completely reversible, that's different from code status.
Okay, yeah.
So
I always feel like, like someone's code status gets reversed and
Then I don't know, like, I feel like I'm like, oh, so I'm gonna unreverse it, like when they're out of the OR, like,
Exactly.
that makes sense to me that they would, like, you know, if that's something that is fixable, that, like, you know, you're not gonna fix the fact that they've got metastatic cancer or whatever, yeah.
Exactly. And, you know, so that's why each and every time we should be having code status conversations. And we used to think years ago that everybody who goes to the OR for any reason should be a full code. That is not necessarily the case. It can still be a DNR in the event that their heart stops while they're in the operating room, unless it's because of whatever you're doing. You know, for the most part, people can just decide to be a DNR or whatever they go. So let's see. Next, let's go through how to conduct code status, or code status conversation, but also a goals of care conversation with somebody who's headed to the OR. So pick a problem, pick a diagnosis that you're taking them into.
Cholecystitis.
Cholecystitis. Okay, should be, knock on wood, fairly simple.
Yeah.
Pretty straightforward. Fixable easily, right? So you talk with them about what the medical facts are. What do they understand about the medical problem? How do they fix it? Do they understand what you're going to do? That's part of consent, sure. But then, you know, as part of, you know, your standard care, in the event, God forbid, that because people do die of surgery even when you don't think that they should, or, you know, they have a bad reaction to anesthesia and bad things go wrong, which is why they have to sign consent to start with, right? So it's important to speak with them, you know, and there's some mixed messages out there, like you don't want to set people up to expect that things are going to be horrible, but we try to normalize the conversation to say, you know, we ask people this, whether you're here for a hangnail or whether you're here at your end of life and everything in between. In the event that your heart stops, how would you want us to care for you? Would you want us to do CPR, knowing that we may break your ribs in a chest that already doesn't work well because you have COPD underneath all of this? If you needed to be on a ventilator longer than during the general anesthesia, would you want us to continue on that way? And, you know, if it's a reversible thing, that's fine. But in the event that, you know, it gets to the point where because of your COPD underneath all of this, would you want us to keep you on mechanical ventilation? If you needed a tracheostomy, would you want all of that? And just to try to normalize the process to say, you know, each and every time we touch a patient, whether it's in the outpatient space where you're seeing them post-op, you know, after they recover, or they're headed into the OR, just to make sure that we're touching on that. Because we always default to full code, and that's still the culture. Is that what you're getting from, you know, the surgical folks here still? Are they talking about, you know, code status, doing anything different than full code in the OR ever? Like, is that?
I feel like even if a patient, everybody chime in, even if a patient's like DNR, we like reverse their code status for 24 hours or whatever. Yeah.
Yep.
Yeah.
We definitely do that for the perioperative period, but I don't believe we are trained to even bring it up. We normally just make most people just a full code unless we are told it's a DNR, but I don't believe that, at least I don't ask, but I'm going to start asking, you know, if the patients want to be a full code or DNR.
Right. So thank you, because, you know, it seems like that it's been kind of an antiquated practice that it's just kind of, you know, our default mode that, you know, because we're giving you anesthesia, because we're opening you up, you're consenting to all of what that means. But there are so many folks we had, and is anesthesia talking about that either, or?
I don't know.
I don't know what their like pre-op assessment is. I mean, I see them come in, you know,
Right.
and ask each question, but I've never stayed or asked if they inquire about those things.
So, one question I have, Jen, is the article I read says that probably surgery is the worst service when it comes to utilizing palliative care.
That
is
was
that
for
the
you
same
to say,
experience you feel?
What's that?
Is that your experience at PACT? Like, do you feel that we don't utilize the palliative care service as much as we probably should?
You have totally set me up for failure with this question. So no, I mean, I think that there's a lot of work to be done in all of the subspecialties because, you know, I have this conversation about 97 times a week with nephrology. Are you really gonna offer dialysis in a 97-year-old with multi-system organ failure whose prognosis is grave before we even start that? How is that an option? You know, can we instead speak about what end of life looks like and how the kidneys fail as the body dies? So no, you guys are not the worst. Absolutely not. No, I think you're doing great. And the fact that we can even, hi, how are you? The fact that we can even have this conversation gives me hope because, you know, there are so many services, so many folks like oncology, for instance. You know, even their national board, their certifying bodies have been recommending that they get early palliative care upon diagnosis of any, you know, grade 3 or 4 stage cancer, and we still to this day are meeting people, you know, on their salvage 4th line chemotherapy. We're meeting them in the hospital for the first time as they're dying. So, I don't know, it's not a contest to be the worst. I'm just hopeful that we can, you know, change some culture, because you know.
Yeah, I mean, I think, for me personally, mindset, you know, I think when a patient gets complex, I think because our group has, you know, our own sign out and round process, I think certain members of our group are strong advocates of palliative care, that it gets mentioned a lot. I certainly don't think that we overlook it, but I also, from my personal opinion, is that knowing there's only a group of 3 of you, knowing the level of involvement that's involved with your end with trying to strategize meetings, family interaction, involving all these people. Like, it's a very time-consuming process for you to introduce and meet and get involved with all these cases.
Absolutely.
So at the same time, like, with only that limited number of that resource, I also feel like I don't want to overly advocate to have palliative care involved too much, because at the same time, we don't want to overutilize you, unless of course you're looking for reasons why the hospital should hire more palliative care staff. And then we can give you all the consults, and then you can argue for more staff. I mean, it's up to you.
Is it up to me? So yes, we do need more help, that's true. But we're also, you know, advocating for, we'd rather meet your patients on day 2 or 3 and not day 14. I mean, we'll do it then too.
Right.
But then it becomes the self-fulfilling prophecy that palliative care only gets involved when people are dying. Well, of course we do. I mean, we do that too. But if you look, remember Jason, the gentleman that I interrupted you when you were having the conversation, he's back in the CCU.
He is, and
He
we
is.
signed off, so palliative is still
Exactly.
following him,
We
but
sure
we're
are.
not.
Yes, so the chest tube was only a fraction of his issue.
Yes, of course.
But you know, it just, you know, we would so much prefer to walk with folks, and we do need more help, you're right. But I also would encourage you to think of us every single time. And that's where we're hoping that you guys will begin or continue to practice primary palliative care. Well, you're already going to touch upon, you know, the healthcare proxy stuff. You're already going to take a look at if they have advanced directives. You're already going to talk with them about code status. You know, you already do a great job with symptom management. You do all of that already. But then if it gets complicated or you start to get in a sticky situation or whatever, that if we could meet folks earlier, we're happy to do that. And we're, you know, we try to be pretty good at triaging too. So if we can't, if we're stretched too thin, we'll be honest with you about that too.
Yeah. I think one of the obstacles I found, because of course I always think of you guys. I mean, I actually was just talking about this last night with some friends at dinner, that young guy, this was a few years ago. I mean, he was probably early 40s. He came in with that terrible neck abscess.
Oh God.
And then he ended up having like the necrotic toe, and he was an undiagnosed, uncontrolled diabetic, and he got the transmetatarsal amp, and then I think he got the flu when he was in the hospital, like all these things. He lived alone, he didn't have a lot of social support, and I mean, this guy was, and I didn't consult you guys because I thought it was end of life, but these were life-changing diagnoses that, you know, now he's on insulin, he's had an amputation, you know, like he has this big wound back on the back of his neck. It was pretty traumatic stuff.
Yes.
You remember that guy?
Yeah.
And
That's great what you did.
Yeah, I think you need it,
Put all that
thanks.
stuff together.
When you guys know how to,
We did.
you know, you provide those resources that we don't have the training in, but I think it's also, you know, a change in mindset of, yes, getting you, it's not just, you know, cancer diagnoses, like, you know, chronic illnesses, it's even these just like acute, like a life-changing event almost. You know, like this person's gonna be on dialysis for the, I mean, that isn't it, whatever. You know what I mean?
Yeah.
But I know often I will, gosh, we should get Palliative involved, and I'll mention it to, some attendees are more receptive than others.
Yes.
And then wording that in the chart in a way to say like,
Yes.
we recognize that this is a concern, and we're, you know, trying to advocate for the patient, but meeting resistance here, and trying to dance that, you know, along that fine line. And then also too, so that's one concern and obstacle. And then I think also too, in palliative care, I think patients and families, they associate it, it has this, you know, negative connotation, or,
That's
you know,
right.
end of life, you know, heavy, oh, this is really serious, you know, like, some of the podcasts I've listened to, like, they say not to say we need to have a hard conversation, like how do they, have you heard?
Difficult or,
Yeah, difficult, or just we need to, like, just changing language that we use all the time
Yes.
to give it a different meaning to patients and families. So I don't know if you can have it help us navigate through those two situations.
So often, I think we end up getting in our own way because of our own discomfort. You know, we bring ourselves into the room, and this isn't as much as it is about our use of therapeutic self and all of those, you know, fancy whatever words, but it's also meeting people where they are. I just met with a gentleman in the critical care unit on Dapotherm. He's 80-something. He's got a gazillion, you know, comorbid conditions. He knows he's at his end of life. I sat down with him, and I didn't say 3 words, you know, before he said, I know I'm dying, kid. You know, just let's go. And I'm like, okay. And so sometimes silence is the best thing, and people will tell you it's amazing. Well, and I swear I have a sign on my head. Like I pump gas, and somebody's like, I have a rash. Can I talk to you? What is it about me that makes you want to tell me all of these things? But you know, he is very much aware that he's facing his end of life. He is working on, you know, putting all of those pieces together. His son was in the room. They've already had some of those nuts and bolts conversation. He's waiting for family to arrive, and he's ready to go. And I'm just helping him sail on the ship that he's already knows he's been on. You know,
I don't know who you're talking about. I think he's a sign-off patient of ours, possibly.
I think that,
Yeah, I saw your note, and I was like, oh, okay, that's where we're heading. But I echo Tori, and I'm sorry, I didn't mean to interrupt you, but that's what I'm imagining. Okay, I'm like, you know, next time someone comes in and they have like a lot of chronic medical problems, this might not be just a straightforward lap pulley, you know, like getting you involved early. And I can definitely feel myself being like, oh, but like, and the patient will get uncomfortable because we're talking about palliative care, and it's like, oh, that's not, we don't mean that you're gonna die, it's just like, and then how would the attending receive that? And they're like, wait a minute, no, I just think this patient, like, we just met them, like, you know, we don't know if they're gonna die. And it's like, I feel myself like, kind of already feeling like defensive towards like, how will the attending react? How will the patient react? Like, how do I kind of navigate and like be this sort of, you know, bridge between them and have you get, I don't know, it's overwhelming to feel like to change the practice like that. But I recognize in hindsight normally the importance of it, of getting you involved earlier than you stepping in at the 11th hour and being like, okay, like, things are looking so good,
now
like,
it's
let's
time
talk
for
about that now.
Yeah.
Exactly.
And so you're not alone in having to dance through all of this stuff, because if the people that you're working with are still under the guise that we're hospice, it's never going to change. You know, so sometimes, you know, the argument can be, you know, you're having trouble with somebody who has chronic opioid use, who in pain management post-op is very difficult. So that can be a time where, okay, it's not end of life care. Certainly, we're hoping for recovery. In fact, they're doing great other than this other piece, and that can be part of it. But just, I know, because I'm going back to some of the conversations this week, and we're still like screaming from the top of this building, like we're not hospice. So yes.
You know, I feel like we need to start purposefully bringing it up more often to the surgeons. I mean, make it like a little 30-day thing. where we try to make a special effort to consider palliative care where they can be beneficial to the patient and their family, and then make a point of bringing it up to the surgeon by saying, you know, this is an issue for this patient, palliative care can help us with that. And start bringing you in more and changing their,
And especially,
program.
I feel like they need an in-service.
It's not a good idea.
You know?
Yeah.
Like, at Palliative Open House, like, this is what we actually
But they
do.
don't have in-service, they don't have time for that, so.
Because I think I think a lot of us are open to it. I think it's more like
Yeah.
the attending to like, you know, this is their patient and we're kind of helping manage, but like ultimately it's really kind of their call. If they're like no palliative, I'm like, okay.
so if they still mean that they don't want the patient to die, neither do I. And, you know, you can describe it as it's not hospice, it's extra support, everybody can benefit from extra support, and I love that
Sometimes
idea.
I get people involved, palliative, I get you guys, and I don't even tell the surgeon afterwards. They'll say, oh, put it up, it's like, because they can help with A, B, C, D. But, oh,
Yes,
and it's already done, so they almost can't say no.
right.
Well, they can't say no then. But you know, so I've done that before, because I know better. But, I mean, I don't know,
do
it's nice
you-
if you had an in-service, but maybe you should, I don't know.
Yeah,
What do you guys think?
and like what Jason was saying, also too, we don't want to overburden you with, you know,
Yeah,
all
'cause
these
I call
consults.
PT and they have like 8 people.
Right.
I call OT, they have a lot of people. You know, you guys don't have
You guys
that.
are
I call physician, you know, they have a lot of people, so we have a lot of patients.
You do, and we too can triage pretty well. We can say, okay, you know, this one, if you're 102, we might start there. But if the goals of care are clear, symptoms are well managed, the family is fine, that may be straight hospice, that's fine. If you're calling with a, 35-year-old who just, who's post-trauma having, whatever symptoms, it would be so great to get involved with somebody who doesn't die.
Right.
I would love
Oh.
that.
Okay.
Well, is there like a checklist of things or guidelines for us to know,
Yes.
like flags that we can say, oh,
Yeah.
this patient fits
Yeah,
6 of the 10
whatever.
criteria for palliative care.
Yeah.
Let's get Jen involved.
Yeah.
I have a
Good.
one slide, thing that's like 3 questions. Would you be surprised if? And it would be, this is perfect for palliative care. So I'm going to send that to you along
Okay.
with the advanced form, advanced care planning documents. Yep. So.
I usually them like, hey, like there's certain patients who they just kind of like scream like palliative care, like
Yeah.
other patients where it's kind of just like
In the way, so whenever, patients ask, sometimes I'll ask,
Yep.
have you heard of palliative care?
Mhm.
And sometimes they say yes, and sometimes if they say yes, so explaining it in a way that isn't, and a lot of times I'll start, and probably my lead or how I explain it probably isn't great, so if you can help me with that, I'll say, a lot of people associate it with end of life, but it's yes, it can include that, but it's
Yeah.
also way more than that, and they focus on the whole, you all
Usually
focus on the
I
whole
ask
patient.
patients, I do the same thing, but I go the opposite way. I say.
And I probably
"We
should
need help-
start-
We need help with A, B, C, and D, and we have a special service who can help you with that. And it's our palliative service, and it's to help
I
you.
feel like
with A, B,
palliative is
C,
a
and D."
misnomer.
And then if they say that,
Is
then I
there-
say, that's not the situation here, they also take care of this.
symptom burden
That's
or
what I
like
try.
something.
Yeah, I try to keep that
That's
out, but
perfect. So,
sometimes people are obsessed with that, and
They
they get
can be.
fixated.
and you see their body language, exactly what you
Yeah.
described.
Eyes
But-
get big.
So usually I just introduce myself. My name is Jen. I'm a part of the care team, the doctors or the team.
My care team.
Yep,
Mhm.
part of the care team. And I've been asked by your doctor, your PA, or whomever to get involved to help you, because what they're recognizing is that you have a lot on your plate. You've been through a lot during this hospital stay, and we'll walk with you through it. So my job, I'll explain the nurse practitioner role in that to say, my job is to talk between and among everybody who's helping to care for you, the surgeons, the hospitalists, nephrology, everybody, and then to talk with you about what those facts are, to make sure that you're understanding what's actually happening with your body, so that you can ask questions. We can talk about what our goals are while you're here, and then to try to figure out, do advanced care planning to say, okay, our goal, your goal is to get through this. We want you to get better. You're going to recover from this hospital stay. But in the event that that's not what happens, to begin to talk about the rest of it. And the word palliative, eventually, at some point, depending on the patient, I'll get to that to say palliative is just literally another word for extra support in whatever form it happens to take. It can be symptoms, it can be goals of care, it can be helping your family. Because so often, as these poor patients, it's okay, thank you. These poor folks, they're so worried not so much about themselves, but how their family is handling, their loved ones, how they're handling it. So hopefully that helps.
No, I like that, just saying, it's like leaving the word palliative out, just saying,
Just normalize
we
it.
have
Yep.
a dedicated care team
Yep.
that can assist with, some of these emotions you're having, or some of your symptoms,
Yeah.
or,
Exactly.
that's, I like that.
Yep, and it just normalizes it. It
Yeah.
You know what y'all come up with, I'll be interested to see. Thanks.
Demystifying it, destigmatizing it, normalizing it. Code status every single time. Every single time. And the more you do it, the better you'll get at it.
Do the ER doctors do that?
We try to encourage that, yes.
Okay.
But often, even when we meet somebody who's been boarding down there on day 4, their code status will say prior. What does that mean? Prior to.
I'm looking now, and I see that all the time.
Yeah, and that should be a hard stop. We don't think they're gonna have a cardiac arrest, but they may while they're on our watch. And so what if they didn't want us to do CPR and we haven't addressed that? That is just as wrong as the other way around, right?
Right.
Just as wrong. So, you wanna just go through one quick goals of care conversation? Just some of the tricks
Sure.
of the trade?
Does anybody on the line have any questions so far?
I have one random question, maybe the other day I thought of this because I had a patient, I think they were DNR,
Yeah.
and they were like not doing well, and I think
Okay.
you might have already been involved, it was like an off hour, and I was like, wait a minute, if they code, like, what do I do? Like, we don't code them, I mean, if they, are dying, like, what do I do? I mean, what you just do nothing, if there's someone who's DNR, DNI, and they're dying, like, actively, like, their heart's dying, just leave it, you just.
So thank you for actually saying it that way, because, so often, people assume that we're either gonna be full code, full court press, do everything, all aggressive interventions, whatever, intubation, resuscitation, whatever, or do nothing.
Yeah.
And instead of phrasing it that way, what we often talk about is that if your body dies and your heart stops and you were to stop breathing in the meantime, we can either do that or we can change the focus of our care to your comfort and allow for your body to die naturally and peacefully when it's time. And it's not do nothing, it's changing the focus and the goal.
Mm-hmm.
Because what I don't want people to come away with is that this is where we get our bang for our buck, or good luck.
Mm-hmm.
We don't stop
Yeah.
caring, we change how we care.
Okay.
And so people get really comforted by that, because if they're, DNR, DNI, you don't do nothing as much as you allow them to go, and assuming that their family hasn't changed their mind or that nothing else is happening, that's when the goal of care is comfort.
Mm-hmm.
I remember when I first started working here, and we had that guy from London with the,
Oh, yes.
yeah, and he was like in his 30s or whatever. Anyway, and he had,
Yes.
terrible kidney failure or whatever.
Yep.
And you saying to me that by withdrawing dialysis was one of the most peaceful ways of going, and I had no idea.
Oh.
I had no idea, and I was like, you said that's probably the most humane thing for him is to just stop dialysis, and for him, and having kind of, and it's one of the other things I was thinking about when reading these articles, like, do you know of any like CME for, us that we could do just,
Sure.
I don't know those things, and I don't know, any of you guys on the line, what it feels like to die from kidney failure, or, I certainly now that I know that, I take that over like COVID pneumonia, probably, you know what I mean? But yeah, but learning more about that I think would also be good for us to advocate for patients and also help to bridge this gap with the surgeons that I think a lot of us feel.
Well, and it is so weird to me still, after however many years of doing this, that, people have a birth plan, right? They know how they want to have their babies.
Right.
They talk about, I do not want a cesarean section, and then what happens, that's what happens. So they, have all of this planning to do. But this is the only other experience that every single one of us has. 100% of the populace will die, and we still don't talk about it.
Right.
People are, I had a 98-year-old the other day. She goes, I've never thought about that, dear.
What?
90, you're like, okay, well, now is the time to talk. I appreciate that.
Yeah.
Never went to the doctor, never did anything, never talked about it. People can ostrich their way, into the next world, or you can have a conversation and give your family a gift. Because if they're not making decisions on your behalf, they're following your decisions out and advocating for that, that's a whole separate animal.
Yeah.
It is, it's tough. And for him, I'll never forget him.
Yeah, me neither.
Just,
I remember exactly what room we were in.
Yep, exactly.
Yeah.
Amazing human, actually.
Yeah.
What else in the interest of time?
For you, so it maybe for, Aldo, Lindy,
Mhm.
Caitlin, you're on the line, explaining that it's you, Suzanne,
Yep.
and Heather,
Yep.
and kind of what your different roles are, and what,
Sure.
if we do have something, we cover 24/7,
Yep.
so if something comes in the middle of the night, like how do we, availability stuff, and then I've always been curious, when you've, assisted with patients, their pain med stuff, we've had some really difficult
Oh,
chronic
yeah.
pain people, and I know you follow up with them somehow, but I don't know where that happens,
Yeah.
because you're only inpatient, so I'm always,
Correct.
and I've asked you, I'm like, so where's the outpatient palliative care center, and you just have laughed, but, and kind of with the vision, and if Bacchus has a vision for, for that, for building something like that.
So I'm hearing really good rumors
Okay.
that there is a plan for such a space. And so the service is myself, the nurse practitioner, and then Suzanne is the LCSW. She's the licensed clinical social worker with the team. And we call each other our work wives, And then Heather is the nurse navigator who straddles Bacchus and Wyndham. So they gave us some help, but now, took on a pandemic in another hospital. But if anything comes in, off service, off time, off whatever, you can always Tiger text me. It doesn't matter day or night, that's just how it goes.
Okay.
That's fine with me, and that's always how it's been. Because I wouldn't ever want you all, first and foremost, as our colleagues, to ever feel like you don't have a resource, because that's a horrible feeling. So I would rather have you call and then, whatever. And, we are, once you put the consult in, we can chat about the case and we can figure out, what you all need as help. Because sometimes it may not be that it needs us. Maybe you just needed, a little hand holding from time to time if, just whatever that is, and we can help to plug in resources. But we're always happy to, no matter what time it is, day or night. And hopefully we'll be getting a medical director before too long.
So Heather, when she goes to Wyndham, you guys don't cover Wyndham, right?
So, Heather is there Tuesday and Thursday mornings most of the time, but we're still all here through Tiger Tech. So even if she's not physically here, we are still in constant communication about folks up there in Hampton.
But when we put in a palliative consult, does it come to your
It does.
inbox?
It
Or
does.
one of theirs, or how do you just divvy it up by,
So here's, let me show you how we do this.
all the details?
Yeah, no, it's important. So this is today. That's our list, okay?
Oh, wow.
So,
many people.
too many.
Yeah.
But that's okay, because all of the COVID folks, everybody who comes in with a diagnosis of COVID automatically populates there. And then the rest of the ones that we have ordered.
These are all new?
Uh-huh,
They're all here?
uh-huh,
Holy.
yeah.
Wow.
How many is that?
I don't even know, I don't count, it's bad for
It's a
morale.
lot.
It's bad for morale.
It's more than so that's 29 patients listed there on the
Yep.
top, and then
Yep.
you probably have another at least 15 or 20 down there.
Yeah.
That's insane.
Oh my god.
So we get good at triaging, and again, I wouldn't ever want you not to do it because
Right.
you're worried about our workload. This is our.
That's why I
everyday.
think giving us that little list you were talking about,
Yeah.
the 3 questions, obviously, and everyone knows that I'm pretty passionate about it. And I think everyone on this call, sees the indication, the purpose, and the benefit, and all that stuff. So I hope as a group we can help advocate and help to kind of do some of the triage work for you all.
That would be great.
But it makes me, you saying to, calling in the middle of the night, like we had that trauma, the EMS driver who was pregnant
Oh,
and lost her baby,
yes.
I was on that night.
Yes.
Would that have been like,
Yes.
okay,
So sure, because things don't happen between 9 and 5, Monday through Friday.
Right.
That's just not how it works. And, I would rather have you have somebody to reach out to, even if in that hot moment, it doesn't need us. If that puts it on our radar to have somebody, that is first thing. That is the number one.
in the morning, yeah,
Exactly. And that's perfectly fine.
okay,
Yep.
that's good to know.
Mm-hmm.
I mean,
Because
it doesn't occur to me at night,
Sure.
you know.
Yep.
Um,
But also, so much of our role too, we've been, patient-centric, patient-focused and all that, but so much of our job ends up being supporting the staff who are watching all of these horrible things happen to people, and, that's our job to say, we just offer support there too. When the physicians lose somebody that they've put all of their effort into, they're devastated, and we just try to pick up those pieces too. So,
and then who does that for you guys?
Yeah, I was just thinking, I was like, someone's got to.
each other, we
Yeah.
laugh a lot.
Mhm.
We laugh a lot. So, I don't know, that's a question for the ages, I guess, but, yeah.
We all really appreciate you.
Yeah.
Actually, another thing I was thinking about, thing I wrote down, is there a health stream that talks about it? Like, I don't know if that's another way to help kind
Yes.
of, dispel the myth,
Yep.
Good idea, actually.
in the
That's like,
Instagram
everyone has to watch that.
Yeah, exactly.
It is so weird that you're saying that, because as part of a Harvard Pilgrim grant that I've been working on for quite some time with a whole conglomerate of folks, we just made videos that talk about these very things. Like, okay, this is what this is what an advance directive is. This is what this is. This is how, when somebody is concerned, how do you handle that? All of the nuts and bolts of that stuff. So it's going to be coming soon, literally, to a theater near you. So,
That's awesome.
yeah.
And it'll be a health stream?
It will.
Good.
Yep.
I think, yeah.
Mm-hmm.
I mean, all the, quote,
No.
silly health streams we have to do, I feel like that's actually a very
Really
important and
helpful
pertinent
one,
one.
yeah.
That would be useful.
Because none of us have enough time. We're,
Yeah, you don't have
stretched
time to
thin.
meet with every group and have this conversation.
Although it's important enough that
Yeah.
I'm happy to do it, because it actually, one hand washes the other, so to speak, and it helps us
Right.
if, people don't think that we're hospice still. That would be great.
Yeah.
I would love a week or even a day where I don't have to say, again, they're not dying, I agree with you. This is the way that we can help them live better in a body that's not working very well, just anything like that.
Yeah.
I'm writing that down. Do you think palliative is a misnomer? Like, has there
Yes.
been talk within your,
Yeah.
Oh,
like,
for years,
field? Okay.
for years in the field, people have called it instead the support team. But at the same time, just because, once you explain to people what we're not and what they thought it was isn't actually accurate, then they're okay with it. Then
Right.
it's no longer a hang-up. It's
Yeah.
our hang-up collectively, not
Mhm.
theirs.
Mhm.
So everybody could benefit from extra support and symptom management and talking about hard stuff in a way that they can understand. That's a universal, they don't have to be afraid.
What did you say? Live better in the body?
In the body that's not working very well.
That's not working very well. Okay.
Yep, helping them optimize, have a quality of life. If after your knee surgery, you can get back to going down to the pond and fishing every day, and if I know that if you can't do that, then you don't want to do this anymore, that's helpful for me to know.
Mhm.
Some people are content if they lived on that couch and
Mhm.
never moved. And watch TV all day long. For some people, that's a quality of life. But for others, if
Yeah.
they can't crawl on the floor with their grandkids, or they can't, I don't know. It's just every person's different.
Mhm.
I'll these generalizations that are, you know, trite but important, right?
Yeah.
Yeah. What else? Anything? Was this helpful?
Very,
Was this helpful,
yeah, yes.
everybody?
Yes, thank you very much.
Of course.
Yes, thank you.
You guys are such a pleasure to work with, and I don't say that lightly. I mean,
Aw.
you really have a very strong team of, you know, excellent clinicians who, you know, are tender too.
Mhm.
So we appreciate that. Yep.
You appreciate me, Jen?
Yeah.
Yeah, we really do.
So I guess so you're in, okay.
Yeah, so I actually was looking for, I know this
yeah.
person is
So
gonna be.
code,
So let me show you. So you go under demographics,
Mhm.
and here it's not there.
Okay.
Alright, so you would see a little, you know, paperclip or whatever. So sometimes I go into additional information, of course it's not there, but at least they have, people in there, that helps.
Yeah.
Your screen is a little bit different from mine.
Oh, okay.
There's also, you go here maybe, there's an advanced care planning, it's called the ACP module. There it is.
Oh.
So sometimes you can find it in there. That doesn't often happen.
So is it scanned in?
Yeah, usually. So if you
Okay.
complete these documents, what you can do is bring them down to the care management office, right next door to where we are.
Okay.
And Elaine Hernandez will scan them in for you and they'll end up into the record. Yep. So, you know, this is supposed to be something that eventually we're gonna teach folks how to use too, because, the goals of care should always be completed, so now they are.
Mhm.
You know, and that's the other thing, so goals of care are
I've
either,
never even seen that tab.
yep, so goals of care are either restorative, right? They're conservative, or allow for natural death. Those are your three levels of goals of care.
Actually, I have one
Yep,
49 who's
that's
now
what it is.
CMO, okay.
Yeah, because his son arrived from Maryland.
Is CMO and hospice the same thing?
CMO means, comfort measures only,
Yeah.
which means not to stop everything, that's another thing.
Okay.
It is to continue all the things that help people to be comfortable, oxygen, medication, blah, blah, blah. But to allow for natural death is the goal right there.
Okay.
And then hospice can come on board.
Okay.
The general inpatient hospice is for when folks have symptoms that cannot be managed any place other than an acute care facility.
Okay.
So if they're taking meds, if they're still eating, if they're swallowing, if they're comfortable, then this is not where they need to stay.
In CMO, where in Alaska, I remember when we would discharge a patient, if they were CMO, like the case manager would have to contact the, like, I don't know if it was like the ambulance or the 911. So
Oh.
somebody, is that the same way here?
So-
Like, so if someone from the home called 911 and, you know, the paramedics came, they wouldn't try and,
So
you know,
now,
resuscitate the patient?
right, so we either put a bracelet on them,
Okay.
to be sure, or, you know, just communicate that with the hospice folks, and that's taken care of. So whenever anybody changes, geography, you change a place, you go from here to a nursing home, they have to readdress code status each and every time you change location. So that's what we try to prepare families for too. We're not hounding you. If you wanna be a full code, you certainly can. You know, we work for you, it's fine, but they're gonna ask you again. Even though we just had this conversation,
Yeah.
when you get to the nursing home, they're gonna ask you again. So we try to, and the only way that they can come in with a predestined code status is if the facility sends them with a transfer DNR. So that's when, no matter where they are, that shows up in their chart. It's, I don't know what color it is now. It used to be orange or something. And that way, they can still remain a DNR. What that means for you and the surgeons, I don't know about that exactly. I don't know if it's still a default. I don't know that. Yeah, well, that's a question that you
Yeah.
should ask.
Do you guys have any other questions?
No, nothing. Thank you so much for the clarification and the information.
Oh my goodness. Well, thank you for bearing with me on a Friday afternoon, on your day off, I guess. So
Thanks
that's
for
huge.
rescheduling
Thank you.
with us.
Oh, no worries at all. And we can talk again if you know
Yeah.
if you wanna. We can do if you want like a goals of care conversation. You know,
Yeah.
talking.
I think that would be good working through different scenarios now and then.
Yeah. I feel like I hear goals of care and I just automatically, my brain again just goes like, boop.
When
And
it-
like end of life, which is like, I mean, sort of, but it's also like, you know, that there are different goals of care, and I feel like I would love clarification on what those are, and also, you know, without illustrations and stuff, so.
Absolutely.
Well, and I think too, probably, you know, as you know, like consults coming in, you're trying to like get your consult done or your HP done, get a mission order done, and
Yeah.
like thinking about, oh, I need to like go through this quote status stuff and go like, you know, it's adding extra things, which I know it's important, but figuring out a way to, you know, I think our team is it's a good, we can help a lot with that, but finding a way that it's not overburdening us, and you know, figuring out a way, an efficient way to do it.
Absolutely.
You know, in a efficient, concise way to do it.
Because, you know, so often, people joke with us, you know, because it will take us maybe 7 minutes sometimes. Hi, how are you? Nice to meet you. Here I am. Who are you? Tell me what's important to you. Who do you love? Who loves you? How do you want this to go? And we'll come out and they're like, how did you do that? Like, I don't know. It's just like you. I mean, when you go, you know, your routine.
You know what questions to ask.
Yes.
Yeah.
And it's just like, I'm sure, you know, you guys, when you go into the OR, when you've done an appy 100,000 times, it's old school. This is no different than that. You do it the same way each and every time.
Right.
And
then
then
you don't forget stuff.
And you don't forget stuff.
Yeah, like having just kind of a rundown of your like spiel or whatever.
Absolutely.
Yeah.
Absolutely.
Okay.
All right.
Thank you so much, Jen. You're awesome. We appreciate you.
Appreciate that guys.
Thanks for joining, guys.
Yes, thank you. Enjoy your weekend.
Aldo, I'm gonna try and post this on your YouTube channel.
Go for it.
Okay. I'll let you know if I have any questions.
Yeah.